Hello. Assalamu alaikum, everyone. I'm Dr. Yusra Salim, an anesthesia resident here in third year, working at Shaukat Khanum Hospital, Lahore. It's my pride here to represent my department and open this session, which is the first session of anesthesia and pain medicine. I would like to introduce my chair of this session, which includes Dr. Almas Iqbal. Dr. Almas Iqbal, I would like to welcome you to the stage, and while I'll give a brief overview of Dr. Almas Iqbal. She's a consultant anesthetist working at Shaukat Khanum Hospital, Lahore, and she has a special interest in pain management. And the next chair of our session is Dr. Asma Ashraf Khan. Please, ma'am, welcome to the stage. She's a consultant anesthetist and airway lead in Shaukat Khanum Hospital. She has done her CCST and fellowship from College of Anesthetists, Ireland. I welcome both madams to the stage. So today our session has 4 talks, and 4 speakers will be presenting their talks. Our first talk is from the speaker, Dr. Feroz Mahmood. Sir, Dr. Feroz Mahmood is here. Ji, sir, welcome to the stage. Dr. Feroz Mahmood is a professor of cardiac anesthesia in the Beth Israel Deaconess Medical Center and also working in the Harvard Medical School. He's a pioneer in perioperative echocardiography. He first joined ASC in 2002, achieved fellowship status in 2015. He has served in the Registry Committee and Interventional Echocardiography Council Steering Committee. He has served on the Society of SCA Board of Directors and a director of multiple echo corps. Sir, thank you for gracing us with your presence.
Thank you very much. It's indeed a pleasure to be here today and a privilege to be invited. And I thank you very much for the organizing committee for doing this thing. So I come from Boston. This is just a picture last spring that I took myself. And the talk is going to be artificial intelligence, do we really need it? The question related to use of artificial intelligence in anesthesia, but I've been a little liberal with my selection of topic and made it applicable to medicine in general. So as here are my disclosures, I'm a consultant for technology development for General Electric for 3D imaging and Abbott Medical Systems for development of MitraClip. So another disclosure, I own a website which is totally free, bostoncardiac.com. It also has a YouTube channel, which is purely and completely free for residents and anyone for education. You're more than welcome to go and visit this thing. This is entirely free of anything at all, So my interest in artificial intelligence started in 2005 when we started doing valve analyses based out of volumetric 3D data. And we wanted to have machine learning algorithms that could reconstruct mitral valve, tricuspid valve automatically without any intervention. And that's what we do, identifying anatomical landmarks in echocardiographic data and then asking the machine to identify them in the subsequent data sets. And that's how it all started in artificial intelligence in 2005. And the most important was for valve and valve therapy, which may be unique or new, something over here in Pakistan, but back in US, it happens a lot, which means people who've had valve replacement once, and you can put in percutaneously valves into them, but that can lead to a lot of complications. And so that's what we used AI for, by placing valves, virtually into a patient's actual data set, and then hypothesizing what kind of complications would it cause. So that was another one of those applications of artificial intelligence that we started in echocardiography in 2005 and 2006. That led to further reconstruction of tricuspid valve, rendition of leaflets. This is all that you're seeing is a tricuspid valve which has been reconstructed entirely by the computer without any interaction or any input by any echocardiographer or any physician. That led to a clinical development of a software called Easy Valve, in which you can see the aortic and the mitral valve being reconstructed out of echocardiographic data, CT data, along with regurgitation, with all quantifications being done continuously and throughout the cardiac cycle, which was a paradigm shift from where the valves are being analyzed. And this took only about 30 seconds to do the whole thing. So this was led to a significant number of publications that we've come through, and I'm quite proud to announce that our group in Boston at Harvard Medical School is kind of considered the pioneer in three-dimensional imaging and the applications of artificial intelligence for reconstruction of intracardiac valves, both statically and dynamically as we go along. We've done that for the tricuspid valve, We've done the artificial intelligence assessment for mitral valve analysis, then for even constructing board-style questions. This is a recent one which one of our fellows has actually used this thing for making these questions made out of ChatGPT, which resemble the same questions that the examiners would ask, and then use them on the residents and showing that it can actually do a pretty decent job in reconstructing these questions. My recent interest has been in structural heart disease imaging, in which valves such as aortic, mitral, tricuspid are all being replaced percutaneously, and we can use anatomical landmarks to reconstruct the cardiac surgical valves. And this has been going along very well. And I'll skip through all these presentations to get to the most important part, and that is the structural heart. This all boils down to this thing, which is artificial intelligence transcending multiple imaging modalities. For example, for our cardiology, interventional cardiologists, when they want to do a transseptal puncture, they have to be shown exactly in echocardiography where to cross the intraatrial septum. Once we identify the intraatrial septum and the septal crossing point in transesophageal echo, that point gets automatically reconstructed as a target in fluoroscopy, which means they know a dot to follow, which will precisely guide them to the point of crossing the intraatrial septum. And this is precisely done in real time with artificial intelligence or with technology that transcends imaging modalities and doesn't understands echocardiography and understands fluoroscopy at the same time. However, having given you this background, the key word which I personally believe, and I'm not, I've done a lot of work in artificial intelligence, that it is a buzzword which is kind of poorly understood and broadly and overly applicable and applied indiscriminately in a lot of things. And a lot of this comes from apprehensions of movies that are based on artificial intelligence, such as the one in Terminator. And for those of you who are old enough to know this Matthew Broderick movie, War Games, in which a kid inadvertently activates the computer to go around to start a nuclear war with Russia. And then the Matrix, movies where it shows that we kind of exist in the world that is created by the computers. Well, that's too far-fetched and sort of conspiratorial in its application. But there are, excitements that are real and unreal. For example, majority of the cars that are built in plants across the world are built by robots. There are automated claim support robots and those things that you can chat with. There's visual analytics that you can apply. These are the things that are all based on, artificial intelligence. And there are some unreal things that we'll have bots that may be good looking, bots that may be excessively strong, who would be doing things that we cannot do ourselves today. While this may be a reality at some point in time, but not necessarily today, and we'll get to the reality of it. And the most concerning part of it is your ability of artificial intelligence to predict, or the predilection to predict, a certain kind of behavior. That's the most important part. And that's something that was referred to in this movie Minority Report, where you could tell by the various happenings of things, the predilection of a crime that happening, and you could go and arrest the people before that actually happens. Believe it or not, that kind of ability or predictive ability exists right now and can be applied sometimes, and people argue that it is one of the most dangerous applications of artificial intelligence. So the AI high points so far in the last and this century have been the IBM Deep Blue beating Gary Kasparov, that was the world chess champion. That was a huge, press hoopla about it. Then IBM Watson won this famous, Jeopardy program in the United States. And finally, the Mars rover on Mars operates and interacts with the atmosphere and makes decisions which are completely independent and autonomous without any human interaction or guidance in these people. And I'm sure you all know what ChatGPT is. People are writing papers, letters of recommendation, letters, emails using ChatGPT. So this is something which is taking the world by storm right now, and that's your ability to create Word files and things like that that are purely based on artificial intelligence and this thing. So with this perspective, the first question comes to mind as, what is artificial intelligence now? Now, this is a contested definition, and most people think that this would lead to something of a transition of decision making from humans to machines, where they would be able to do and make things and which are much more accurate, much more dispassionate, without all the hoopla that the humans have in decision making, and that's what artificial intelligence is. Broadly, this is correct. This is accurate. Somewhat of a correct definition and representation of what artificial intelligence eventually will be. But the correct definition of the dictionary definition of artificial intelligence is that this is the simulation of human intelligence by software-coded heuristics. Heuristics are circuits, just like neuronal circuits in brain and spinal cord, which can act on their own without interaction. These are those things which are called reflexes. So you essentially have higher wisdom, higher level of thinking and decision-making, acting on a reflex level without significant interaction by the cerebrum. So artificial intelligence is actually a broad term which starts with deep learning, which is a subset of machine learning in which multi-layered neural networks learn from vast amounts of data. That leads to machine learning with algorithms that perform and improve as they're exposed to data. And finally is artificial intelligence, which is a program that can sense, reason, and act and adapt subsequently. So where do we stand in this whole paradigm of use of artificial intelligence is a matter of debate, but at the end, I'll try to see where it is. And if there's one single evidence of artificial intelligence that has worked, it is the Mars rover program, which essentially shows that billions of miles from Earth, there's a machine that can act, that can sense, act, adapt, and then react completely independently, making rational decisions and sending the information back and trying to make those decisions, which are irrational, which are according to the circumstances, and adapt those decisions as the circumstances change. So this is kind of the the penultimate or the highest level of machine learning that can be adopted and can be demonstrated, which is now being done in this Mars rover. Now, keeping that thing, my definition of artificial intelligence is when you get a college degree, but you're still stupid when you graduate, because what we need is not artificial intelligence. We need some common sense here. So let's go over the history of artificial intelligence. So this is not our first infatuation or our laziness when we want someone else to do our job. It's across history. People have called these automata, which was in Greek mythology, in Middle Ages, during the Renaissance period, during the 18th and 19th century. And in the golden age of automata, we've always thought of things that can, thought of beings and machines that can actually work for us and can do things that we can better than us and without any interaction, sparing us to do bigger and better things in life. So this is not the first time that we've tried to develop something that does things for us that we could have done ourselves, or maybe better than us, and spare us the time to do bigger and better things. And now I give reference to this Enigma machine. If anybody knows, this is the German coding machine, which was used in Second World War, and the breaking of this code by Alan and Turing led to people breaking all the German ciphers, and they were able to win the war. The gentleman who did this was Alan M. Turing, who in University of Manchester was the first one to ask this question scientifically, that can the machines think? A brilliant cryptologist and a brilliant computer scientist. He hypothesized that the meaning of the word machine and think ought to be found by examining how they're commonly used and difficult to escape the conclusion. And ask the question, can the machines think? So this was Alan M. Turing asking the first question. And this was also the basis of a very famous movie, Benedict Cumberbatch, that's The Imitation Games, in which an observer was put to ask questions to a computer and a real human, and based on their responses was supposed to guess whether this answer came from the computer or whether this answer came from a human. This was the imitation game. So the computer was imitating a human. And at that time, in that paper, not more than 30 to 40% of the time that the human was able, that the observer or the person who was interacting with the computer was able to establish with a certainty that this is a computer or a human. But he hypothesized again that in due course of time, with additional computational power, it may be possible to have those machines which have responses which are completely indistinguishable from humans. Just as a matter of trivia, Alan M. Turing was gay, and he was persecuted in England because of that, subjected to horrible experiments and therapies, and eventually bit on a cyanide-laden apple in University of Manchester and died. And some people think that the symbol of Apple computer with a half-bitten edge of it is based on that reference to Alan M. Turing eating this cyanide-laden apple. Incidentally, I've been to that office where this happened. So the first phase of this technology was in 1950s, was the idea, when computer and machine intelligence, computer programmed to play checkers, and the most significant development of artificial intelligence in the 1950s was this Dartmouth conference that happened in New Hampshire, in Lebanon, where they collected all these computer scientists on artificial intelligence and tried to put together algorithms to do that. The next phase, I call it the maturation phase from 57 to 79, when a lot of things happened. And the most significant of this one was called the Stanford card, which in the University of California, Stanford, they had this card that shows on the slide, which would take maps and would take books and reports and exams from one department to the other without any interaction, just being told what to do. These are a lot of things that happen in the maturation phase in between 57 and 79. Then came the AI boom, when the first government in the world was Japanese government that put in about $500 million in 1981 for research in artificial intelligence. And then there came the first autonomous drawing program. And the last was in 1997, the first big one, the commercial program, Electrius, which was automated strategy managing advisory program. Then came the winter in also 90s when the computers became very cheap. And now comes the thing that most of our computers, what they do is artificial intelligence. They're just machines that think for us, do things that we don't want to do it ourselves or be found it too cumbersome to do it. But now in 2011, with all this buzzword, the things that have happened so far, like I said, Deep Blue beats Kasparov in chess. Windows releases a speech recognition software. Cynthia Brazell develops the first robot with human emotions that can actually interact. And last week, somebody read in the New York Times, and actually with a chatbot, a 12-year-old kid committed suicide, talking to a chat and getting emotionally involved, and then killed himself. This is like crazy level of emotions can be demonstrated by these machines. Then NASA lands 2 Mars rovers in 2003. Then an AI-based focused social media advertisement. Then Watson wins Jeopardy. Then Apple releases Siri, and then comes to the current point where we are. Google has programmed to recognize cats. Like that makes a difference. And then Stephen Hawking and these people have actually proposed to the governments, written a letter that we cannot have AI or autonomous weapons be launched or be developed at all because this is so dangerous. We have a humanoid robot, Sophia. Facebook develops 2 robots that can talk to each other. Chinese Alibaba got into it. Then OpenAI develops Chat GPT-3, which is on the 5th revision of it right now. And lastly, we have now a Dolly software that can understand and recognize images, which is the basis of a lot of retinal scans right now. So based on all this information, the question to ask is, do we really have a problem that AI solves? Or do we have a solution that is looking for a problem to solve? I squarely said in the latter campus that this is a solution for which a problem has not been invented as yet. And what is the problem of these kind of solutions is? A problem is presumed to exist, a solution is implemented. In fact, the problem never existed. And then we have solution causes more problems that never existed in the first place. So it is just one solution leading to more problems than, as a matter of fact, leading to some solutions. And then you have to find your way around it. The classic example is internet itself. This is a very famous book, Not in God's Name. Jonathan Sachs from England wrote this book, which deals over the fact why society is becoming so polarized and why people are becoming so extreme in their opinions that they refuse to talk to each other. And that's because of focused news advertisements, because of intellectual insulation. Despite all this information, it's possible to insulate yourself from alternative point of view. If you listen to CNN, you think this part of this narrative is absolutely correct and the other is absolutely wrong. For those who listen to Fox, think that what they say is absolute nonsense, and there's no middle ground, is fast going away. And that is leading to polarization because people are becoming ignorant despite more information, isolated despite being more connected, and finally, we are having more information, but that's not necessarily good information. This is not the first instance when we've had solutions without problems. For example, in 1970s, NASA created a fund for $15 million to create a pen that could write in zero gravity. It could be erased in zero gravity on the moon, in space, on Mars, and everything. Guess what? It was $15 million. Guess what? A pencil could do exactly the same thing. So it is not the first time that people have spent millions of dollars on solutions for problems that never existed here. So my personal opinion is that we don't need artificial intelligence in this world. We need common sense over here. So in this outline, I'll briefly touch over what AI is, the national trends in healthcare, the healthcare challenges that are ethical and legal, and then finally what my own word is. So everything starts with data mining, which means you have to collect, put some data into it, and then eventually further decisions are made based on that data. So the collection of data determines the quality of what you do down the line. If it's garbage in, garbage out, you have bad data, you'll have bad decision making. The national trends are that FDA in the United States has approved 3 programs: the medical imaging platform for MRI analysis, autonomous screening for retinal scans, and then osteodetect that detects distal radial fractures, like you need artificial intelligence to figure it out whether the wrist is broken. And again, this is not the first time in the world that people have spent millions of dollars on stupid and bizarre inventions, such as Snuggies, Doggles, Koosh balls, singing fish. Each of their portfolio was in excess of $25 million on Wall Street. And they were absolutely useless inventions that had absolutely nothing to do with your practical life. The ethical challenges with artificial intelligence are even more. For example, are we going to go tell the patient tomorrow that we have reached this decision based on artificial intelligence? Well, that sounds very sexy, very good. But are we going to tell them that real intelligence wasn't involved in this thing? There was only artificial intelligence. I don't know how it was reached, this decision, but it wasn't involved. That's the stickiest point. The second biggest problem with artificial intelligence is the black box algorithm, which means we can control the inputs, we can get an output, but we have no idea how this decision was reached. There was no rationale that it presents to making that decision. And that is one of the biggest problems, that not even the people who design those algorithms know what are the basis of those specific decision-making problems. And that's called the Cody's algorithm to predict cardiac arrest in Netherlands. Was great in telling patients to go to a certain specific hospital for better resource utilization, but they could never tell why the software is telling me to go to this hospital or this. You just have to have implicit and explicit trust on it and try to do something like this. So that's one of the biggest problems with AI right now. We talked a lot about IBM Watson for the Jeopardy program, and the same supercomputer was applied to reading of histological slides and mammograms. It was found that it was a total bust. It missed a lot of breast cancers, and at the same time also missed a lot of slides with oncological cells on it. So either it was overly sensitive, leading to a significant number of false positive, or overly specific when it would miss a lot of those stuff. So the point is, if it needs supervision for every decision it makes, this is twice as much work for the same amount of endpoint that you're going to get over here. So the other bigger problem that people touted the very big impact of artificial intelligence was on algorithmic fairness and bias, which means that we would at least have somebody who is not biased in making a certain specific kind of decision. Well, the evidence and the facts are quite to the contrary. When we, despite the potential for democratization, globalization of healthcare, there is a significant risk of bias, and that's even more than what the humans would say. For example, the people who own the data, people who monetize it and discriminate and theft and right to withdrawal are all those problems that have not been sorted out with the use of artificial intelligence. And we believe that it addresses the problems that we have in fairness and bias of algorithms. It does not. And the legal challenges are even worse. In Obama's administration, they exempted all the softwares from FDA, put them on a fast track, put it this way. They put it on a fast track and exempted them for the medical decision softwares that do not fully fit the medical device definition. This was all done to fast track everything into market. And that was the source cause of all this problem that we are facing today, that everything in the United States, the buzzword AI, and it sells like hotcakes. And so the liability wasn't sorted out. For example, if you make a bad decision based on something that the AI has said, who's liable? Is it the physician? Is it the software? Is it the manufacturer? But who's likely to be held responsible for this thing? And we have not sorted out the hardware software incompatibilities. And we are all aware when Windows 11 comes on in a computer that should have had Windows 10, and all things go haywire over there. So those are things, the hardware software incompatibilities haven't been figured out over here. And the last is the data protection and privacy. In England, one of the hospitals in Leeds, I think, they had an issue with giving the Google DeepMind unidentified data of patients for analysis, but based on digital triangulation of when the car showed up, when patient checked in, and what this happened and when that happened, they were able to not only have pictures of those patients, their home addresses, their car license plates, and their home telephone numbers. So that's called digital triangulation, and this is a farce that making it anonymous would make it fair somehow or other, or unbiased. So it is even more dangerous in data leaks as opposed to what the humans do with that. And lastly, I'll give you like 7 important methods in which the AI fails. This is like mind-boggling if you look at it. The first is its brittleness, which means it doesn't recognize any pattern that it hasn't seen before, which means if it hasn't seen a bus before, if it sees bus, it will recognize as something blank. That has led to a lot of accidents in Tesla, automotive driving and everything. So brittleness is a reflection of the shallowness of what it learns, which means it learns only the things that it has been shown. It doesn't infer based on the rational decision making that if this one looks like this, the second thing will look differently and how they're interrelated with each other. The second is embedded bias that I talked about in the beginning, that in one of those studies, they assumed that people with high healthcare costs were also the sickest patients and most in need of care. However, due to systemic racism, Black patients are less likely to get healthcare when they need it. So the sicker patients are minorities, people of color and everything. To make it more economically viable for the system, it just triaged them, those patients, less of those patients to the ICUs, and therefore led to more bias and discrimination that any human would do. The third is catastrophic forgetting. This is called whitewashing, which means as it learns more information, it keeps forgetting the ones that it learned in the past. So it's quite possible that the AI has a tendency to entirely and abruptly forget information it previously knew after learning new information, because it doesn't necessarily mean that the same new information on a specific topic does not erase the previous information, but only complements it. The fourth is explainability, which is the black box algorithm, which means some decision has been raised, but you don't get an explanation of why this has happened. So therefore, that's one of the most significant of these things. The last is quantifying uncertainty. It is very good in quantifying the certainty of a certain specific process happening, but it cannot quantify uncertainty. What is the chance that this is not going to happen? This is called the gut feeling. We call the gestalt, which I think this is going to happen like this. This is something that the AI is completely devoid of. This is the root, the basis of our clinical decision making. Trust me, is a gut. Like they say, medicine is taught as science, but more or less practiced as an art. This is not an art that can be taught, that the gut feeling can somehow be incorporated into AI. The sixth is common sense. It lacks significant common sense. For example, in those websites where any word that relates to Jew, that relates to gay, that relates to Black is considered a hate speech, and they would classify those websites as those websites that are furthering hate speech and all that kind of nonsense. And the last is math. You'd assume that the AI would be great in math. No, it is not. It is very poor in math. It is making good in decisions, complex algorithmic, statistical analysis, but 2 + 2, and most of the time in AI is 5. So it's not all good. It has a long way to go, So, and therefore, going back to the big broad definition of AI or what it is, if there is anything where we stand right now, it is at this stage. When we are at the machine learning algorithm phase, when algorithms are being created whose performance is getting better as we go along, we are far distant, a long way from the point where we can have completely autonomous programs without any significant supervision in the world as general and medicine in specific. That's a long way from where we are right now. And the decisions of these computers are just faster. They're not necessarily any better than you and I can make at this stage. And I finished the talk with this famous example of Icarus. This is Daedalus, a mythical inventor, created wings made with feathers and wax to escape from Crete in Greece. And however, he ignored his father's warnings and flew too close to the sun. His wings melted and fell into the sea where met his end. The question is, the concept was perfectly fine to explore the sun. The point is, did he have the goods to do that at that point? The concept was perfectly fine to fly, but you don't have to jump off the Eiffel Tower to prove that you can do and die about it. So do we have the goods to do we have the software right now, or the authenticity of a software right now to have something which is completely autonomous, making decisions for us without any supervision and any consequence? So was Icarus a visionary or just a stupid guy? It really depends. He was visionary. He wanted to fly to sun. We still haven't been able to do it. But wasn't he stupid in knowing that wax would melt his wings and he'd die on the way? So that's something for you to think. So I personally think at this point in time, we do not artificial intelligence. We just need natural common sense. Thank you very much.
Thank you so much, Dr. Feroz Mahmood, for such a riveting and compelling talk. It was a pleasure to hear your perspective on this. Moving on to our next speaker.
Yusra, can we have a question and answers now or at the end?
At the end.
So now I have one question that you have touched it briefly, that in medicine a lot of data is actually sifted through by the AI. And do you think there is a risk of disclosure of information of patients' data and information during this process of collection, sharing, and use?
Absolutely, 100%. So this is one of actually the greatest fears of artificial intelligence, is that the fail-safes that we have for the leak of data. And having worked with some of these companies at a very high level, believe it or not, this data is worth more if there's weight in gold. We think it's totally useless, but for these people, it's everything. Everything they do is based on data, and they do anything like this digital triangulation, which was based on purely, for example, if a patient showed up at 10 o'clock and they say the mammogram was done at 10:15, they would go and look at the cars that checked in 15 minutes before, get all the numbers over there, see all the bills that were sent to a specific address, and about 5 minutes would be able to tell what the name of the patient was, their car license plate, their telephone number, and eventually what the other problem was. So that is a huge, huge concern, as yet unsolved right now.
So I have a question. So AI, most of us think that it's the devil. It's going to replace humans. All the folklore literature that you've pointed out. But what we see is that actually the presence of AI, like to give an example, in healthcare and in industries worldwide, has actually improved improved efficiency. It's improved working. So at the end, are we going to see human beings being replaced by a better form, which will actually be better, or is there a sort of middle ground with the AI?
So that's a great point, and that's is redundancy of human labor. That's the real value, is that would application of these algorithmic process lead to a redundancy of human labor? So the answer to this question is no, because you'd be absolutely delegated to bigger and better things in life, and this whole apprehension comes from these movies where we found an autonomous Skynet comes on in and takes over the world and kills everyone who's doing anything. But eventually, at some point, we will be doing bigger and better things. I personally think so. I'm an optimist, at the same time a provocateur in artificial intelligence. But it's the thing of the future. And then when the change is introduced in your life, there's only two options. Either you become its victim or you drive it. So you can choose to become its victim by not adopting it, or drive it by adopting it and modulating it so that it does the best for you rather than the worst, and not these apprehension fears. The worst would be making weapons which are based on artificial intelligence. That would be, and eventually somebody will.
Yes, I got a comment and a question. The comment is that you talked about liability, and Harari in his book, like Nexus, goes on and says the liability lies with the companies that are developing those algorithms. So do you really think that anybody's going to fix that liability at some point?
So liability is a touchy subject, and everybody is this referred to as a tort reform in the United States, that who is responsible for what percentage of damage that happens to the patient. So it's as yet there have been not many lawsuits of use of artificial intelligence in healthcare, because it's a broad learning algorithm, but people have missed mammograms. People have been sued for missing mammograms based on, reading, which said perfectly fine, and you go ahead, and then the lady eventually ends up having. So it is right now being discussed in the context of individual practitioners, because you're the one at the end of the day who's going to press the button.
The second is that surprisingly, I was asking some questions of this ChatGPT, and surprisingly, it came up with stories, concocted stories where it couldn't find a good answer.
Yes.
And so they say it depends on the training algorithms. Now, I was going back to our education system and the way our students are taught, and this is what they do. They don't have answers to the questions, and they come up with stories explaining them. And this is what all of us humans do. So isn't that very, very human?
That is true. That's what I'm saying. Reminds you of what we used to do also. But it is getting better. The latest version, if you look at it, it is unbelievably specific in getting what the answer is. All right. Thank you very much. Thanks a lot.
Thank you so much, sir. Again, it was a pleasure to hear you talk. Next presenter will be Dr. Ehtesham Khan. His title is Perioperative Outcomes: A Moving Paradigm. Sir, I would like to introduce you a bit. He's a consultant anesthetist working at Royal College of Surgeons Hospital, Dublin, Ireland. He completed his fellowship from CPSP, did his FCAI and diploma in pain medicine. He's also a master's in medical professionalism from Ireland and got fellowship of Joint Faculty of Intensive Care of Ireland, a member of Council of College of Anesthesiology of Ireland, and as the first non-native Irish, he is the chair of the Vice President, chair of the Credentialing Committee of College of Anesthesiology, and Vice President of the College of Anesthesiology Ireland. Please give a big hand to Dr. Ehtesham Khan.
Thank you. Good morning. I think after a very colorful presentation from Professor Feroz, it will be hard to match the colorful presentation which he has done. But thanks, fine. My topic is perioperative outcome, and it's a moving paradigm. There are a lot of things happening to improve perioperative outcome in the last few decades, but it's still there is a lot of things can be done and are being done in this area. So situational awareness will be my talk. What exactly situational awareness is? This situational awareness has been in the airline industry for decades. And it has now started coming into the healthcare as well, and anesthesia and the operating theaters as well. So my first few slides and first few things will be to explain what exactly situational awareness is and how exactly it is impacting healthcare and anesthesia. So it's been there for decades in the airline industry, and it's now coming in. But my few slides, I will try and explain what situational awareness is. So a lot of Pakistanis must have heard of this airline, PK8303, on 22nd of May, 2020. This flight, PIA took from Lahore and was heading towards Karachi. And the flight captain, Sajjad Gul, he was an experienced pilot. And he, under his belt, has more than 17,000 hours of flight time. First officer was Usman Gul, again, good experienced co-pilot. So now the aircraft, when it was approaching Karachi, was at the altitude of 3,000 meters. At that level, when the flight should have been at around 900 meters. So you can imagine the flight was very high compared to what it should be at that level. Now, at that point, there was a communication between the air traffic controller and the pilot. Your plane is not at the appropriate height, and you should have been much lower than expected. So what you should do, you should go around and come back. But the pilot disregarded the air traffic controller's opinion and his advice. And he said, no, I will be able to land this plane. So he disengaged the autopilot, and there's a landing instrument that gives you how exactly will be the angle of the flight coming into the to land. Now, this is the data that came up from the afterwards, what exactly was happening. And you can see a very steep descent of that flight, of that aircraft. And it came, and when it was about to land, the pilot at that point realized, I have made a mistake. So he put up the landing gear and tried to go up, but it was too late. So what had happened, the engines of the aircraft touched the tarmac and then went up. But what happened, they went up, but both engines were gone. And when the flight went up, the pilot realized both the engines had failed, and now he has to just land without the engines. So this what happened when the flight was touching. This is the CCTV picture of that flight. As you can see, there's a bit of a fire just when the flight was touching the tarmac and then went up. And as both engines were gone, and this what happened. And that flight landed in a very, very busy residential area where more than 100 people died of this in this accident. So there was an investigation. The flight crew, what came up was violated the operating procedures, and they ignored the instructions from the traffic controller. And what exactly came out was a lack of situational awareness. So in this, there was nothing wrong with the aircraft. The pilots were quite experienced, but they lacked the situational awareness, what exactly was happening at that point, and ended up having an accident. A second case, United Airline Flight 173, December 28, 1978. This flight was going from John F. Kennedy in New York to Portland, Oregon. And while on the flight, they have to have a stopover in Denver, Colorado. So again, this flight captain was Melbury McBrone, a very senior pilot. First officer was also quite experienced and had an engineer as well. All three of them are quite experienced. And you can see from the details below, he was 27 years airline pilot and had more than 27,000 under his belt, a very experienced pilot. So what happened when the flight took over from Denver, Colorado, and was about to land in the Portland, there was an issue with the landing gear. And now what happened, all the three crew in the flight, captain, co-pilot, and the first engineer, just got concentrated to the landing gear. And while they were it took them a lot of time, and then the failure to recognize the aircraft is now, there's not much fuel left. And by the time they realized there is not much fuel left, this what happened. The flight crashed. And luckily there was not many, so just in the Woodlands, this airline crashed in 1978. So I think there was 12, 13 people died. It was lucky not many people died. But again, there was an investigation, and the result was fuel exhaustion due to pilot error. And you can see all three crew members just concentrated on one thing, and they didn't realize they have lost there was an error with the landing gear, but that could easily would have handled. And again, what the conclusion was, the whole crew didn't have the situational awareness, what was happening in that flight. So there was a word, this thing coined, crew resource management. It's been there for ages, but after that, this has now become part of the training of the all the pilots, and it's just to overcome the situation. One of the things is situational awareness and few more things, and this is now also coming into healthcare management and in anesthesia crew resource management. And just to give you an idea, a small bit of a thing is we still use is if you do a huddle before the start of the theaters, or the checklist WHO. So we are trying to get into that thing, but this crew resource management is still on the way in medicine as well. So once I have discussed a couple of airline things, I'll move on to the see what happened here. British tech billionaire Mike Lynch, he was the first billionaire of United Kingdom, and he's known as the Bill Gates of UK. There was a company known as Autonomy, which was bought by Hewlett Packard. And what happened after a couple of years, the Hewlett Packard realized we have paid too much, and Mr. Mike Lynch has exaggerated the price of his company. So they sued him, and this court went on for a couple of years, but then he won the case. So once he won the case, he threw a party And that's his luxury yacht, 40 million luxury yacht. And this incident only happened 3 months back, nearly 3 months back. So this was, again, just like a Titanic, unsinkable ship. And so he called his friends, and altogether they were around 20 people in this boat. And they were just outside, just some miles out of Sicily, where they were. Now, before they left the port, there was a weather warning of high winds. And also the surface temperature in the Sicily was 30 degrees Celsius. That was more than 3 degrees more than the normal. And that can create a lot of small storms, tornadoes. And so they missed the weather warning. So when they went up in the night, they were water spout. It is just like small tornadoes. And the keel is a thing under the ship, which normally, if you are going towards the shore, you pull them up, and a boat or a ship goes towards the shore. They have the keel retracted, which they should not have, and the hatches was open. And when the tornado came, as the keel was retracted, their boat spin, and the hatches were open, the water came, and so the whole ship sank within few minutes. So again, the crew was very experienced. There was nothing wrong with the ship or the boat itself, but still the ship sank. And at the end, when the initial investigation showed it was a series of human errors caused this yacht sinking. And so the ship was, people said, at the wrong place at the wrong time. Again, an error of or a loss of situational awareness that led to this accident. Now, we are doctors, anesthetists, so I move on to what happened in medicine. Mrs. Elaine Bromley. This again, I've tried to create this AI picture from ChatGPT, and I was trying to, so it's not the real theater environment. I just try to do that. But Elaine Bromley, it's a very, very famous case that happened in 2005. And after that, a lot of practice in theater or anesthesia and intubation have changed after that. Uh, Mrs. Bromley, she was a 37-year-old woman, and she went for her endoscopic sinus surgery and septoplasty. Malampati was fine, and she had a congenitally fused vertebra. But because of that vertebra, she did not have much issues with her neck. Mouth opening was fine, and there was no issues with the flexing and the extension, just slight rotation on, that was the only issue. And the plan was to give a GA with reinforced laryngeal mass. That was the plan for anesthesia. Now, what happened? Dr. A was a quite experienced anesthetist, and tried to insert an LMA, and wasn't able to do that. So patient desaturated to 40%. Miss Dr. B, who was again a very senior anesthetist next door to the in next theater, he came to help, and he tried to intubate, wasn't able to intubate, and patient was desaturating. So the situation becomes can't intubate, can't ventilate situation. And it was an ENT procedure. ENT surgeon was also in the operating theater. He went on to the head end and tried to intubate, but he also failed. So for 25 minutes, patient saturation was in the lows 40. It went up, they tried to bag mask, came down, the patient was struggling. And after 25 minutes, decision was made to wake the patient up. Now, once the patient saturation improved, transfer to recovery, patient did not wake up, transfer to ICU, intubated nasally through fiber optic, but patient died of multi-organ failure a few days later. This was a big incident and in United Kingdom, and that changed the practice after that, a lot of things. So there was an inquiry. Professor Mike Harper was asked to look into that. So there was nothing wrong with the hospital, nicely equipped theaters, qualified and experienced anesthetist, and staffing was good, and there was everything available for intubation and everything. And also there was a percutaneous tracheostomy and the surgical airway available. And while this was all happening for that long, one of the nurses came up and suggested, oh, there's a tracheostomy as well, but she was ignored. And can you imagine the whole, nobody went, and the DAS guidelines came back a year back in 2004, which has all steps, what exactly you should be doing in that sort of a scenario. So everybody missed the anesthetist A, B, and ENT surgeon, and they just kept on going with that thing. Martin Bromley, he was a pilot, and he still is a pilot, and he was the husband of that patient. So he was looking for answers, what went wrong. After a couple of months, he did got the answers. Now, the good thing was, rather than just criticizing the doctors and the healthcare system, he thought, okay, I have to correct and I have to sort these things. So he made this a group, clinical human factors. And since then, he has done a lot of work in that area, and he gives talks, and he has really, but one thing he found out after all going through that is, all the medical system is very much exposed. If something like this happens, we don't know how to handle it. So a lot of loss of, so again, in that operating theater, with all the experiences, every facilities, there was a loss of situational awareness, what to do going forward. This is another case which I was involved in, a 75-year-old female, ischemic heart disease with 3 stents, congestive cardiac failure, 35 to 40%, COPD, grade 3 kidney disease, and hemoglobin of 9. So you can see this woman is quite sick patient to start with. She broke her hip, and there was the first surgery done, and she had a DHS done, but that did not work. So 2 weeks later, she was scheduled for second surgery when I got involved. So she was for a short gamma nail initially. We did a spinal. And then when the surgery started, the surgeon wasn't able to put the short gamma nail. It was changed to a long gamma nail. And again, after half an hour, 45 minutes, while into the surgery, now it was nearly 2.5 hours, planned to change it to put a plating there. So it all took around 3 hours, and there was a 3-liter blood loss. You can imagine now it's time, the spinal is coming to its end, and the patient had total no clue, and he just sucked into, I have to fix this hip. And this was the result. As you can see, this is a bloodbath. This surgeon kept on going, and changing from one plan to another. And he didn't realize where exactly the patient is. So as I was the anesthetist, this was a mnemonic. And I think this mnemonic should be now in every operating theater. And I kept on saying, I'm concerned and I am uncomfortable. And it is getting, and he kept on saying, what, you want me to stop this surgery like this? I said, yes, you're not into the abdomen where you have the gut open. You just close it, pack up and come out. And at the stage come where I have to ask him to stop the surgery, and which he at the end did, and we moved the patient to recovery and then into the ICU. So now hopefully the audience understand what exactly is the situational awareness I'm talking about. And it's a failure to perceive a relevant clinical information, and inability sometimes to comprehend what's happening. And that sometimes leads to inability to anticipate and plan. So, and it's a cognitive skill. And the thing is, just in a simple words, knowing what is going around. And from Pakistani, I could easily say what exactly is going around when we are driving onto the roads. We are not only taking care of our own cars, but we know somebody else will come from the side, and then we have to anticipate. That's what we're doing. So it is a similar thing when we are into the operating theaters. We should know what exactly is going around. And what causes situational loss, lack of situational awareness? There are lots of things: fatigue, distraction, stressful, high workload. All these are contributory factors to the loss of situational awareness. But there are 2 things which I would like to point out. One is the stressful situations. For anesthesiologists, there are 2 times when we are starting anesthesia. That is a stressful situation. And then when we are extubating. So these are the 2 stressful conditions which we get involved. There are other factors as well, and the government, the big institutions should look into. The doctors are not fatigued. Distractions have come into nowadays with our mobile phones inside the theaters. Once we put the patients to sleep, a lot of us are on our mobile phones and the other things. And one more thing is poor mental models. As we go senior in any specialty, we don't tend to listen to our juniors or any advice. And that what happens in poor mental models, we don't listen to, even if it's the nurses or any other juniors. If things are going wrong, no, I know better, I will look after this case. And then these things do lead to a lot of incidences that had happened in the past, in the 5-6 situations I have given it to you. So once you lose your situational awareness, you just concentrate on one thing and you exclude what's happening. You lose communication, and whatever are the established procedures, like in the first case, there in the airway case, there were established guidelines. And even for the pilot, there are established guidelines. You just leave those guidelines and awareness, and you just start thinking on one track. And now there is an evidence why exactly situational awareness is important. It has come into healthcare, and that is, in a lot of cases, it's the genesis of a lot of harm. And your judgment is compromised, and your decision making is also compromised. And all these things leads to patient safety issues. This is a study that was published in Anesthesiology in 2017, frequency and type of situational awareness errors contributing to death and brain damage, and in close claim analysis. That's a big data. And the guys who did this study, what they did, they look into what the claims were. So there were nearly 10,000 claims in that database. So they looked into from 2002 to 2013, they found 2,000 number of cases from related, and then they were brain damage or the death around 800. So they kept on getting, and what they came up, where exactly the solo anesthetists were involved, they looked into, there were 266 cases. That's what they found. 2/3 or 74% of the claims was because of the situational error, what the anesthesiologist made, and that contributed. So you can see how big this issue is. Now we have trained our doctors, training is good. Anesthesiology over the years, the monitoring has really come up. And even after doing good knowledge, good training, and having a lot of monitoring, still we have got errors like this that's contributing. So it's a big number, and it's very alarming. And if you can look into, mostly these complications were respiratory, not able to intubate, patient got aspirated, hypoxia, and few more things that led to this thing. But now, once we know what situational awareness is, how exactly it's important, how what are the consequences, but now the question is how to improve. There are a few things which we can do to improve, and one is simulation. Gradually, we have got now nice mannequins, and we can create a lot of scenarios which are already, we knew, like, so they are difficult scenarios, and we can do it outside the operating theaters. So we can do one thing, observation. So one thing is we need to teach our trainees not only to look what exactly, but to critique as well what's happening. And that will leave, once the situation like this happens, which I have given 4 or 5 examples, they will be able to cope better. And there should be flexibility, not only as you become senior, more flexible you are, you will be open to take more from even from the nurses. Sometimes they will come up. And I have seen practically a lot of times nurses have saved us by giving something, a clue at the, we need to, so these are the things. And also if you are going and identify things much earlier rather than late and learn from your mistakes. I think in a lot of hospitals, you do have got morbidity and mortality meetings. In our hospital, we have got the SIM forum, that is Serious Incident Management Forum, where all the cases in the hospitals come to the senior body. We discuss those cases, and that has led to a lot of improvement in the healthcare, and definitely improved the teamwork. The one thing which I have mentioned about the crew resource management, and that classically talks about the teamwork in the operating theater where there are 6, 7, 8 people, and that's a very important team. We should communicate, and there is no hierarchy. Okay, no, I'm the boss. If that thing comes up, and that really helps, especially when the things are getting quite thing. So as Donald Norman mentioned in Psychology of Everyday Things, if an error is possible, someone will make it. And even after a lot of improvement and knowledge, training, I can tell you still there will be mistakes. But if we improve situational awareness, the chances of errors will go down. And also, if there are ever any error or any harm happens, the consequences, we can just make sure it doesn't go too very extreme. And so it will help once we have improved in the situational awareness. So what we need to do, still perioperative outcome, there are a lot of things needs to be done. And one thing what I have realized now, the situational awareness, we need to work on it. We need to do a lot of things to improve that. I think now the doctors are getting much more better trained. There is a much more better monitoring in the operating theaters. One thing is the selection of our medical students into a medical college, which in Pakistan is still what I realized, you get some certain number of numbers and you get into a medical school. But in the Western world, especially in the United Kingdom, selection of the medical students have also changed. And a lot of things which I have mentioned, they do now check whether the students have got those capabilities, like say they are able to critique, they have got flexibility, they will have a lot of interview and a lot of things before they are selected. So only your numbers are not important. There are other things as well which we are looking into. How to improve getting a better doctors in the healthcare system. Thank you.
Do we have any questions? I have one quick question. Thank you so much, Dr. Sham, for this very useful talk. Do you think that teaching the non-technical skills like situational awareness is as easy? Because I feel that teaching a technique will be much more easier as compared to teaching a non-training NTS to the residents and the trainees.
It's very difficult, but Asma, one thing, if you realize this is an issue, like situational awareness, which I have explained, and it can be improved if you allow your juniors to critique your practice or ask what exactly we are doing, and is there any other way to let them think. So that is one way of, and one more thing, as I have mentioned, selection of medical students. In our health setup, it's only the numbers. But if you look into whether we are selecting doctors or somebody going into are able to critique their observation and they are thinking out of the box, so we will get a good cohort. And so I think there are difficult ways, but you can teach them and teach them flexibility. And by simulation, a lot of these scenarios can be improved. I know situational awareness is not an inborn thing, but there are ways which I can go wrong. It's another talk. What exactly can be done to improve situational awareness?
Thank you.
Just a quick question, if I can ask Dr. Sham. You have worked in both the countries, in Ireland as well as in Pakistan.
Say it again.
You have worked in both the countries. Do
Yeah.
you find that the cultural context is quite important in countries like ours, where we have a very high power distance? It's relatively like difficult for the trainees to speak up, and it's just because of not only how we train them during the training time period. It has to do a lot of cultural aspects as well, the way we were raised. So do you find that the two places are different in that context, the culture?
Definitely. It is, it is different. And that's why I brought this thing up. And I think in hospitals like Shaukat Khanum and in Aga Khan, where these things are, we should allow our juniors to, and it's not the case. Here, a junior will never question my senior. Whatever he's doing is right. And I think we should encourage our juniors to do that. There's definitely a cultural difference. And I can tell you, not only the junior doctors in Ireland or in the Western world, even the nurses will challenge you. And sometimes it's very good. They'll challenge, oh, your dosage is not right, because we don't know. So they will challenge us. And the junior doctors coming from Pakistan sometimes feel, oh, that nurse has said this thing. And I said, no, that's right, because they do it. And even if they are wrong, it's nice to go back and check. And you are all doing for the patient. but definitely a cultural, there is a difference. And I think we should encourage not only junior doctors, but nurses as well as part of the whole team. They're all the crew in that operating theater to come and challenge us. Yes,
So
Dr. Said.
one of our team leaders is team leader nurses is just sitting at the back. She's very happy with that hands. So I just one question regarding outcomes. So since you gave the example of the airline industry, we still have a long way to go in the airline industry as well. A few years ago, there was a Malaysian airliner that vanished into thin air, and there's still speculation about what happened there. So coming to my question, how do we go from here? So there's a lot of talk about situational awareness. We're just starting our discussions regarding this and human error. But is this a thing that we can actually negate at any time? I know we've come to a place where we've improved outcomes to 1 in 30,000 or 1 in 50,000 in routine surgeries. But that one error, is there going to be a time that we say that we can negate that one as well?
Good question, Dr. Saad. But Saad, if you look into over the years, like say this database in from America, Close Claim, more than 10,000 cases. Once you start one incident, it may be happening in your hospital, but it may be somewhere else as well. So if you try and improve that one thing, there may be a lot of other things are improving because of that. So like say capnography, when it came into practice, so it was not only the mortality went down, but other lot of improvement as well has come up in the perioperative. So what I understand from your question is, if you're looking into one improvement, am I right in saying that? But I think these are the things, day-to-day practices. If we keep on doing those things and improving, and overall your doctors, your nurses, and everybody will realize we have to look into, even if it's an error is a small, is a sort of a trend in improving that. Thank you. Thanks.
Dr. Etesham, for your enriching thoughts and experience on this topic. It was definitely an engaging talk. Moving on to our next speaker, Dr. Fozia Mir. She's a consultant anesthetist in St. George's, London, Lahore Hospital, London. And her interests are in difficult airway management. She's currently the DAS treasurer, the DAS database co-lead, and ASM lead. She's a regular faculty in advanced airway courses regionally, nationally, and internationally. She's the co-author of DAS Awake Tracheal Intubation Guidelines that were launched in November 2018. I would like to welcome Dr. Fozia Mir on the stage. Her topic is human performance when things go awry. Please, ma'am, welcome to the stage.
Okay. Thank you very much to the organizing committee for inviting me here. It's a great pleasure and honor to be part of this fabulous meeting. And thank you very much for the very kind introduction. So for those of you I haven't met before, my name is Fozia. I'm an anaesthetist and I work in St. George's Hospital in Southwest London. In the next 20 minutes or so, I'm going to talk to you about human performance when things go wrong, things are not as expected. It's a very hard act to follow, Dr. Khan and Dr. Mahmood, but I will try my best. The first thing to say is nobody paid me very much to do anything. So anything I present in this lecture is all my fault. And yeah, I have no conflicts of interest. This is where I work. I like to show this picture because from the outside, it seems like a very calm, serene, beautiful place. Inside's a totally different story. It's mad, it's chaotic, it's super busy at the best of times. And since we've had the helipad, which brings us trauma patients from all over the southwest of London, it has become even more busier. But what that means for us as clinicians is we get to see really interesting cases, really interesting trauma cases, including airway management, and a lot of focus on human factors and multidisciplinary training and teaching, which I get is the theme from the Symposium at Shaukat Khanum this year, that you've got very well-established multidisciplinary teaching sessions organized. So that's where my interest comes in human performance, in human errors and causation, and how we can prevent them. So human performance in emergency airway management is a very hot theme these days. There are human factors involved, like in all other specialties, and your performance does impair when you're faced with stressful situations. So what is stress? Like all emotions, stress is not inherently good or bad. It's when it's the wrong intensity, if it happens for the wrong duration, with the wrong frequency, and is the wrong type for a particular situation, that stress becomes bad for you. And our response is influenced by our assessment of the situation we're faced with, which we declare as a stressful situation. So if our demands for the situation versus resources are not balanced, that's when the situation becomes stressful. In any emergency, in any difficult case we're faced with, if our resources are sufficient, both personal and environmental resources, then you see it, your mind sees it as a challenge, not as a stress. And that supports your performance. So that becomes optimal performance situation zone for you. But if your demands outweigh the resources, i.e. you're not prepared for the situation, you don't have equipment, you don't have the ability or techniques to manage the situation, then it's perceived as a threat, which leads to a negative psychological state and impairs your performance. And what happens physically? How do you notice you're stressed? So few of the things which have been mentioned in literature are tunnel vision, potentially leading to decreased situational awareness, which Dr. Khan has very adequately mentioned in his talk. And you start missing bits of information which can actually be very, very helpful, vital for your management of that situation. You get auditory exclusions, tunnel hearing, which we call, which impairs the communication. So very often in a stressful situation, people are trying to tell you something. Look, you've missed X, Y, and Z, but you're so stressed and you're so super focused on that task that you miss that information. Your perception of time changes. It either speeds up or it slows down. I'm sure in a lot of clinical situations, we would have noticed we're faced with a difficult intubation. You're trying to intubate, you're trying to bag mask. And in your mind, you think it's been 2 minutes, 3 minutes, hardly, but actually it's been half an hour longer. And that's a very known, well-known, well-established fact. So your perception of time changes. Peripheral vasoconstriction is a very common occurrence, but we don't see it very often, except that things like when you've just dealt with a difficult situation, you start writing notes, sit on a table, and then you may notice there's a fine tremor in your hands. While you're writing the notes, your writing becomes a bit more illegible than what it is for doctors. And that is peripheral vasoconstriction and your high sympathomimetic tone, which physically manifests at that time. So how can we modulate our response, and what can we do to make it more of a challenge state rather than a threat assessment state? And if you look at it, our physiological responses of the body are dependent on how we perceive that state. So a challenge state will lead to an improved cardiac efficiency, dilatation of your vasculature, and low cortisol levels, which are all positive things to happen. Whereas if you see it as a threat, then you get peripheral vasoconstriction, diminished cardiac output, and your cortisol levels rise, and you get more stressed, and then you're unable to manage the situation effectively. And there are 4 major steps at which this type of situation can affect your behavior. So you can have an impaired perception of your problem. The problem may be bigger, you see it as a small thing, or it may be small and you perceive it as a big thing. Your analysis of the problem is impaired. decision-making is impaired, and the motor action, the things which you actually need to do to solve the problem can be impaired as well. And what's our response then? So our response can be fight, flight, or it can be freeze. So fight and flight are very traditionally set responses to stress, but very often you see when it's an extremely stressful situation you're faced with, you don't feel capable of dealing with it very well, you just freeze in the moment and you just are unable to think, to progress, to do anything to solve that. And it is very commonly seen. You get an impaired concentration, a slow decision time, leading to impulsive behaviors, rescue fever, which we call it, where you rush into things which you shouldn't rush into, make decisions which you shouldn't make, and that's all related to stress. As we said, it also leads to a loss of situational awareness. And for this reason, amongst all others, stress does impair team performance as well, because you start affecting people around you with your stress as well. We see selective attention in stressful situations, which allows us to focus on a single object. And under pressure, if you think about it, your attention is naturally focused to the locus of stress, the center of the stress. And therefore, if the stress is intrinsic to the task you're dealing with, your performance is not affected badly. But if there are external stresses around, your attention is drawn away from the task and your performance is affected. Now, examples of what I mean by this sentence is, if you are faced with a difficult intubation as an example, and you're focused onto the patient, on the task at that time, there are no external distractors for you, you may be able to think better, plan better, and have a better patient outcome. But if there are external stresses like relatives shouting, unhelpful team members screaming their head off, somebody knocking on the door, surgeons after the helpful 30 seconds ask you, how long are you going to be? Your attention is drawn away from the task you should be focusing your attention on. And that's when your performance is badly affected. So we always say during takeoff and landing, no external person is allowed into theaters or in an anesthetic room for that reason. Your performance in divided tasks, those that require an integration of information from several sources, like CPR situation, pericardiac arrest situation, they do suffer under pressure for that reason. So this is a short video which I'm going to play just to demonstrate how the stresses can affect our performance. So this was a paraglider. It's a real life scenario. He had a camera attached onto his gear. And he jumped, the parachute failed to open. There's a rescue bag which parachuters generally carry with them. Oops. And I don't know what's happening there. Let me try to play it manually. So there's generally a rescue pack which they all carry, which you can open in the event of a failed deployment of your first parachute. He tried to open that, but the ropes were so tangled up, he failed to open that as well. Now, as you can see, this is a very stressful situation. He's all on his own. All the focus is on at that one task to open the parachute and save his life. And he's frantically trying to open it, and the ropes are tangling more and more. So at the last minute, he just rips off the bag. The rescue pack opens, and he lands. Now, I can't think of any more stressful situation one can be when you are moments away from the inevitable. So that just shows if your attention is undivided, you can make things work. So how does stress impact our memory? So our working memory is impaired in the context of a stressful situation when you see it as a threat. Whereas if you see it as a challenge, there's no impairment. But what is more interesting is that stress has less of an impact on memory retrieval in those individuals who carry a lot of experience. And that's why we say that those people who have been hands-on for a long time, doing the same thing again and again, their memory retrieval and their working memory will be a lot better. And that's why experience counts. So for those of us who've done, I don't know, 10 years, 15 years of anesthesia, will have a different working memory pattern to those who've done maybe two or 3 months in anesthesia. So practice makes you better. It does make you better. Our decision making, how's that impaired? So there's a greater reliance in shortcuts when you're stressed. There's a reduced ability to analyze complex situations. Reasoning is impaired. And generally under stress, you tend to favor the lower risk or more certain options. So the things which you've done before, things which you know work, and that's where the concept of algorithms came. So if you are in a stressful situation, your mind is not thinking straight. But if you have something hanging on the wall telling you plan A, B, C, and D is what you should do in a difficult airway scenario, it's more likely to work for you. And then there's tactical fixation, meaning the failure to change strategy when needed. So you become so focused on one thing, you're definitely sure that your X laryngoscope is going to work for you, despite the fact that you failed 3 times, but you can't move away from it. And that's what we call tactical fixation, which is commonly seen under stressful situations. So what are our physiological responses? There's a range of responses which we see. So initially, you might see an increased alertness, increased concentration, because you're just identifying the situation like unfolding around you is stressful. So your pattern improves first, then it plateaus, and when it becomes extremely stressful, it deteriorates. As we said before, you see a change in your fine motor skills, leading to complex motor skills. Then you start getting perceptual changes like tunnel vision, tunnel hearing, and then your time perception changes. So an example of this, as I said before, is after the stressful situation is over and you start writing notes sitting in a quiet place, you might notice a fine tremor in your hands. And you might notice that your handwriting skill has deteriorated even more. And that's because of the catecholamine release, which had happened during that stressful situation. The zones of performance, human performance, have been very, very well described in literature, and this is one example of those. So you can actually divide it in different zones, starting from white, yellow, red, gray, and black, depending on how stressed you feel, what physiological responses are seen as a result of that stress, and what your heart rate is in response to that stressful situation. Now, why this is important to understand is all of us have different optimal zones of working under stress. So it varies from different activities. So as an example, military and police performance, where your performance requires more gross motor skills, condition red is the most optimal zone of performance. So if we look at condition red, it's that one above the condition yellow. So you can cope better if you've got a slightly higher heart rate than zone yellow, for example. Whereas in medicine, there's more of a reliance on fine motor skills. So we might perform better in condition yellow, where you're a little bit more chilled out with a lower heart rate, better physiological state of your body. But why is it important to understand these zones? It's important because you can actually expand your zones with training. Meaning if you've had adequate training, if you've practiced the same scenario repeatedly multiple times over the years, you can actually tolerate a higher level of stress before your performance diminishes in that particular zone. So we have a very narrow margin where we get optimal performance in stressful situations. Too little stress is bad for you, it leads to boredom. Too much stress is bad for you because it leads to overexcitement, and both ends are not good for you. So for any activity, there's a balance between your skill, your resources, and the demands being placed on you. And that is what we call the flow state, which we strive to achieve under stress. So if your demands outweigh your resources, we see anxiety, poor performance. And when your skill or confidence outweighs your demands, then we see boredom that could degrade your performance as well. So now the next question comes, how do you learn stress management? So although we all have different starting points, but stress management, like all other skills, can be learned. The first thing to do is master the craft, because that comes first. Put your time in practicing. There are techniques which ensure that you're able to perform at the very high level you're capable of, even in really stressful situations. But you need to be well-versed with the actual technique first. Then you need to prepare your tools. So have a well-rested mind, sleep before you come to work, you're well-fed, well-watered, and that will put you in an optimal performance zone even before you start the task. There is stress exposure training, which comes through education and cognitive preparation. Skill acquisition rehearsal, both problem-based and emotion-based coping mechanisms can be taught through simulation. An application of these skills in real world or in simulated settings with reflection and feedback. These are the traditional ways of learning how these skills can be learned. But all of them focus on clinical skills first, and then stress management to be taught as a separate skill. Mindfulness is one of them, which helps, and it's a skill of deliberately being attentive to your experience as it unfolds. So without being focusing on other stresses around you. It improves your ability to focus and to focus your attention on the task itself. It improves your working memory, and it may counter the impairment of working memory caused by stress. So how to practice being focused, how to practice being mindful. So broad awareness or situational awareness, which Dr. Khan very adequately mentioned, is very, very, it's an essential skill you need for leading any stressful scenario like a resuscitation, difficult intubation, or failed intubation. So when you're performing a specific skill like difficult intubation, where you require a much more narrow scope of focus, but if you're focused with, or if you're faced with a CPR situation, you need both a narrow focus and a wider focus. So how do you practice that? You can easily do that while at work, any one day. Just pick up any object you have in your anesthetic room, in your theater room, like a laryngoscope. You hold it in your hand. You feel, see how it feels like, how heavy it is, cold, not cold. What is it doing to your hand? How is it appearing to you? So your attention is undivided on that laryngoscope at that time. Then you take your focus of attention away from that laryngoscope, focus on the room around you, see how many people you have in theaters, who is doing what. If you're faced with a difficult situation, identify what qualities each person has that you can use to help you in that situation. So by this mental rehearsal, mental practice, you can actually also practice to focus your attention where you need it in an emergency. So if you do have a situation like a failed intubation and you have to do emergency front of neck access, you would have already rehearsed in your mind that this person can do this for me. This will be the runner. This will get me the scalpel or the bougie or the tube. And therefore, because you've practiced the scenario, your performance will be better. Also, because you would know that you can easily switch from a narrow focus to the wider focus because you've practiced again and again. Holding the laryngoscope, looking around, and then focusing back on the laryngoscope again. It can be any object around you. It doesn't have to be that. So, but what I said was, this helps you in situations where you're not even thinking about it, and you can perform better. So I like to show this interview where this footballer is being interviewed, and as you can see, they're chatting. I wish the sound was a bit louder. They're chatting, and he didn't even looks back, but he knows there's a ball coming, and he catches it just in time before it hits him. That's what we call experience. So he didn't look back, but he knew from the sound that something's coming, approaching him. And because he's so familiar with his equipment, with his techniques, he's able to save himself. And that's what we need to strive for. One way you can do this is by overlearning a skill. Overlearning is a concept which has been very, very commonly demonstrated and talked about in anesthetic literature. So what does it actually mean? It means learning after your basic competencies are achieved. So once a skill is overlearned, it becomes almost automatic, part of your routine technique. And then it requires less concentration, less working memory, and it improves your performance under pressure. So one example which I can think of from our everyday practice is something like driving a car. So you learn how to drive a car, you pass your test, and then you keep on driving the car, probably going through the same roads again, coming out of the same parking lot again and again and again every single day. You do it involuntarily. You don't do it because you're still practicing how to learn the car driving process, but you do it involuntary every day. It's a repeated task for you. And what it does for you, it makes it ingrains it in your working memory. So one day, you don't even have to think about where you're reversing, where you're moving your steering wheel to, how do you have touch control and all that. You can just do it automatically. And that muscle memory comes with extensive practicing of your skills. And that makes you better to cope under stressful situations. So if you are, unfortunately, you're going to be faced in a road traffic accident one day, or about to have a collision with another car, you'll be so well versed with the maneuvers of your driving skills that you can easily save yourself. So this is another video. So I'm not a sports person, but I really like showing these videos with this footballer, Michael Jordan. I'm sure some of you might have heard about him. So he's so well versed with his skills. If you look at him, he's going through there. He tries the normal way first, fails, and then he comes from the other side and throws the ball in a reverse fashion and achieves his goal. Now, he didn't have time to think about these maneuvers. He did it, and he did it so well because he'd done it millions of times probably. So it's ingrained in his working memory. He knows if one way doesn't work, he has a second one, third one, fourth one in his pocket. And he can use any of those maneuvers to achieve his goal. And that's what we need to be masters of our skill, to save ourselves when we need to in a stressful situation. So part of this can come from mental practice, like we looked at, which involves visualizing in as much detail as possible each step of the skill which you need to practice. Now, in medicine, mental practice has been shown to enhance surgical and procedural skills, and it improves performance in team-based trauma resuscitation simulations as well. And one aspect of it is skill of taking control. So sometimes you may feel your department, for example, doesn't stock the right equipment for you, or there are no right protocols. Don't feel stressed or helpless about it. Get involved. Involve other people in your team as well. Ask everybody to contribute, and you will make it better for you, a working environment for you. In stressful resuscitations involve the entire team in decision making, both because you benefit from other people and other people may benefit from you as well. And remember, all team members in your team do not have the same stress coping mechanisms. So a junior nurse in your team may be able to get more easily stressed compared to you because she may have seen less of these than you, and vice versa. So stress is a very subjective thing, and we need to remember that. Having a plan of action limits indecision as well. So you will take more time to make a decision when you have more choices. So you go out in the market, you're shown 20 dresses. You'll find it more difficult. You'll take more time to choose which one you want. And similar, in basic physiology lab experiments, it's been shown that if you have a number of responses to a stimulus, if they increase from 1 to 2, your decision time actually slows down by almost 50%. And for the reason for saying that is that's why you have things like the DAS failed algorithm for airway management, because you are given limited choices. You're faced with X, you do Y, Z, and then you achieve your goal. Ergonomics are very important. So know your room well, know your equipment well, know where you need to stand for doing an awake fiber optic, for example. Where should the patient be? Where should the monitor be? Because all these things can help you. Status display provides information such as altitude, similar to like our monitors tell us, this is the saturation level, this is your heart rate. And command display is a concept from aeronautics again, which tells you what you should do in response to that information. So it tells you pull up, pull down. Imagine if our pulse oximeters will just say, okay, SATs are 95, you need to start thinking about something else. It hasn't happened yet, but you never know. Then techniques for regaining focus in stressful situations. How do you do that? So you're doing an awake fiber optic, you lose control, you don't know where you are, you fail to identify your anatomy, which can happen to a lot of us. So when you're lost and you're unable to identify landmarks and you feel your stress levels rising, go back, identify one anatomical feature which you're 100% sure of. So for me, it will be going back
to the uvula level. And then I know, okay, that's the center, and I need to just go beyond it, and epiglottis will hopefully be somewhere there, and then I'll see the glottis behind it. So you need to find your own anatomical landmarks, your own starting points where you're comfortable with. Go back to that starting point and start again. But all of these optimal performance techniques will only work if you've got the actual basic skills. There's no point telling yourself I can do it. No amount of positive talking if you actually don't know how to do it. So you need to master your practical skills first, and then focus on practicing the stress management skills and your human factor skills. Cognitive offloading helps. So you should have a plan ahead of time. So for every patient coming in, have a plan A, B, C, and D. And that's where the concept of algorithm comes. That's why algorithms were made, because it tells you you need to follow these steps to achieve a Y outcome. Checklists help you. So we have an intubation checklist, RSI checklist. In moments of stress, when you're unable to think properly under the heat of the stress, if you have a checklist at hand, you can actually see if you've identify if you missed any step. Standardization helps. In a stressful situation, you don't want to be faffing around the whole room, throwing out everything out of the box, looking for one piece of equipment. If you already know this drawer will have plan A, plan B, plan C, you can easily pick up your things better, and you would know what to do. So you don't waste cognitive work searching for things or trying to find an alternative to what you're used to. And then remembering there's a parasympathetic backlash. After every stressful situation, after every difficult situation you're faced with, there comes a period when you actually lose focus, because you've been through that. Your body gives up, your mind gives up, and you sit down, and it is difficult. Then you're more likely to make mistakes. So after having, for example, a difficult intubation, you've got the tube in, you start the ventilator, you forget to turn the gases on, because your focus, your attention has gone, because that stressful moment has passed, and now you're relaxed, and then you make mistakes. So how do we deal with that? First thing is to acknowledge that it exists. We're all human beings. This is a period of vulnerability. And then you try to regain situational awareness. Having checklists, example, post-intubation checklist, a pre-CT checklist, pre-transfer checklist, having colleagues around you, nursing staff, ODPs, students, trainees, encourage them to help you out, check out on you, and have a break. Even a 5-minute break can help you a lot. And then having a debrief after the event that helps participants come to terms from whatever happened and learn from it. Now remember, debrief should not be a finger-pointing exercise. It's to help everybody in the team to understand the process and how to make things better for next time. It should be voluntary, not forced. You can't just pull people and say, you have to have a debrief today. No, you can't do that. It should come from within the person himself. It should ideally happen in an environment away from where the stressor took place. So ideally, don't do the debrief in the same theater suite where the difficult or failed intubation happened, and should be offered in the context of ongoing psychological support. I have tried to address a few of these things, but in the limited time, I think I've just given you a framework to work on, and all of us can work on these things to make our techniques better under stress. Anybody who makes eye contact with me this year will have to listen to how great the DAS meeting is going to be this year, and you're all welcome to attend. Happy to take questions at the end.
Thank you, Dr. Fawzia. Do we have any questions from the audience for Dr. Fawzia?
So first a comment, it was a very nice presentation. And, actually every time I look for mindfulness and things, I just saw a person sitting in the garden like this. So I never knew that you can do the mindfulness exercises in the theater. So my question is there a way, like have we developed, even like in UK or like College of Anesthetists or Royal College has developed something to learn those things, like, because this should be part and parcel of our anesthetic training. So I would like you to please share as a resource or a course or anything which we can just do and practice to master those skills. Thank you.
So as such, there's no recommended thing which I can say because I will be biased, but I know there are a few courses which focus on human factors. One such course was the Liverpool Adam course, which was advanced decision making under stress. One was train the trainers at the Royal College. So there are several courses, and most of them are simulation based. So you can easily set up a course here for yourself for the local trainees who might not be able to go on international courses for the traveling reasons, but it's very easy to set one yourself. And actually, you don't even need very advanced simulation mannequins and things to work. You can make it stressful for them. So for example, in our airway workshops, one of them was a front of neck practice station to make it stressful for them or more real life. We asked the participants to run around the hall 5 times and then come and do the front of neck axis. So their heart rates have gone up, they're running around, they're under a little bit of pressure, under a little bit of stress, and then you time them and say, okay, you have 30 seconds to do it. So that puts the stress in their minds and in their bodies enough to mimic the physiological response which you'll get in your difficult airway. So things like this you can do locally here, even if there's no well-established human factors course yet.
Just make them more stressful, isn't it?
Make them more stressful by artificial means.
Thank you so much.
Thank you, Fawzia. I think excellent presentation, and lot of questions with Asma has come up from Fawzia's, from my presentation. And I think my presentation of situational awareness can easily be turned into. But I think stress management, which is part, and what Fawzia has now said, I think going forward for our trainees, we have got a good training structure, we have got good monitoring. I think this situational awareness thing is now should come into on all those 6, 7, 8 points which we have mentioned should now be part of training of our residents. But thanks, Fawzia, for clearing up a lot of things. Yeah.
No, I'm glad you were asked all the difficult questions. Thank you.
Thank you, Dr. Fawzia.
Thank you so much, Dr. Fozia, for your delightful talk and a topic as important as this. It was definitely an immersive experience for all of us. Moving on to our next speaker, Dr. Arshad Taqi. He's a consultant anesthesiologist in the Indus Hospital and also a medical director at QF NST campus in Lahore. He also served as the Department of Anesthesia at Children's Hospital Lahore and a consultant in anesthesia and critical care with Call Associates. He's also a member of the critical care faculty and one of the founding members of Price Network. He also served as the president of PMC. Dr. Arshad Taqi, topic is safety in NORA. With greater complexity comes greater responsibility. Please, sir, welcome to the stage.
Assalamu alaikum. So if things got to go wrong, they shall go wrong. So that explains the change in the topic from what is shown in the program. And I won't go into the details, but somehow we had a terrible kind of failure of communication, I think, as much as on my part as on anybody else's. So my brush with non-operating room anesthesia came back in first in 1993. That's a long time ago. I guess some of you were not even born then. So there's this hotshot dental surgeon, a friend of mine, who was treating all the elite in the town and in other towns who had practice in multiple towns. He introduced that's dental implants. So he would be put those titanium implants in those patients, which was an expensive business, and so his clientele was really. So one fine day he says that they really are anxious on the dental chairs. So is there anything that you can do about it? And I said, fine. We are friends, so whenever we get a chance to sit together. So that was a nice chance to actually sit and have a cup of coffee while he was working, share some gossip, and actually be paid for it. So they paid well. So that was like real nice stuff, easy. The only drug at that point when we started was diazepam. So you really had to titrate, make sure that the patients had it. And interestingly, some of them who had some experience of alcohol would say, Dr. Saab, ek pack ka maza aa gaya. That's what they were fun. And then we got other drugs, and then I had more work to do. So that was this job was passed on to the residents, and they were handling it. But this out of non-operating room anesthesia has moved forward, and now it has become a part of our job, a regular part of job. The number of patients operated outside anesthesia rooms are increasing. The complexity is increasing, and the patient population is also changing. Now, a lot of patients are sicker. They're coming from ASA 3 to 5 classes, and the percentage of patients who are operated outside the operating room in cases of NORA is more than the patients, ASA 3 to 5 class patients operated in the operating rooms. So this is serious business for us. This is our own data, which shows that steep curve. And once again, what we find is that we are moving from those simple cases to more complex cases. Now, compared with the OR, the NORA patients have a mean higher age, which is 3.5 years higher. 37.6% of them actually come from ASA class 3 to 5, as compared to 33% from OR cases. And generally what we find is that we actually get lesser chance time for optimization of these patients as compared to OR. So the process of pre-anesthetic assessment and optimization is generally compromised when we are dealing with these patients. We really don't have a structure in place. To top it up is the complexity. We talk about non-operating room anesthesia as a singularity, as if there's that one set of places, one site where we are working. It has multiple sites. Each one of them has their own unique challenges, and each one of them have their own set of populations. To top it up, my experience in life. There are places where you are needed, but you really are not wanted. So this is one of those places where you are needed, but you really are not wanted. So there's little room for you when you called. So it's a remote location. You got limited working place. Most of the times, the proceduralist is coming between you and the monitors, certainly coming between you and the airway. The gastroenterologists would not really are notorious for that. And I see one sitting there actually smiling. So your line of sight with your monitors is often impeded. The lighting is poor. The temperature may be suboptimal. You don't have skilled person around you. The drugs and equipment really are maybe, if you are not planning them, then you may be lacking in drug and equipment when it is needed. And this is once again a sample of our data from 2019 to 2022. We haven't analyzed 2023 so far. And what we find is that majority of patients were done under sedation. So then that's the trend that we see everywhere. Most of these patients are done under sedation, which also means that these patients are done with unprotected airways, compromised respiratory monitoring because your traditional capnograph is not working. So, and also we know that transition from light sedation, which we are supposed to provide, can rapidly move on to deeper sedation. bordering on anesthesia with a compromised airway. And interestingly, the data I'll share in a while shows that we really are not really called when the procedures are being done under light sedation. We are only called when deeper sedation is needed, often as in emergencies. So my question from particularly the younger lot is, so is the risk of complications and adverse events greater in NORA than operating room anesthesia? Do you really think the risk is greater? How many of you say yes? Raise your hands. So most of you. Okay. So let's find out. So talking about the characteristics, generally the mean age is almost the similar with slightly higher age group in case of non-operating room anesthesia. The gender, there's much it's a fair distribution between operating room and a non-operating room. The percentage of patients coming from ASA 3 to 5 is higher in case of non-operating room anesthesia as compared to operating room anesthesia. The percentage of emergent cases is higher in case of, so most of in a high about these cases are 2 times or more than twice as likely to be emergency cases as compared to operating room anesthesia. Primary anesthetic technique, as I've suggested earlier, is sedation as opposed to operating room anesthesia. Once again, if we look at the liability claims from those closed claim projects, what we find is that substandard care is harm is attributed to substandard care in 54% of cases of non-operating room anesthesia as compared to operating room anesthesia. And in 32% of cases, it was suggested that the patient could have survived or harm could have been prevented by better monitoring in 32% as opposed to 8% in operating room anesthesia. The payments made, the compensation made is generally higher in case of non-operating room anesthesia. The incidence of claims is higher in case of operating room anesthesia adjusted for population. However, the incidence of death and disability is higher in case of non-operating room anesthesia. So the patients who are harmed are more likely to be seriously harmed in case of non-operating room anesthesia. But please remember, all the data that I'm sharing is about 10 years old. That's the last analysis that we have seen. We haven't really seen more updated, and things are rapidly changing with NORA, with that increasing population. So this is not recent. I'm sure things would be different if somebody started looking at more recent data. Once again, as this is coming from NECOR data, which comes from those malpractice claims, what we find is that non-operating room anesthesia, 19% of the claims of total claims come from non-operating room anesthesia versus 4% of claims from operating room anesthesia. And in case of malpractice, like suites, the number of cases is like 81% GI, whereas the number of claims is only 51%. So radiology and cardiology make the bulk of those claims. So they are considered to be those areas, kind of risky areas, dangerous areas. Once again, the incidence of death and permanent disability is higher in case of non-operating room anesthesia. So I agree that non-operating room anesthesia carries a higher risk. However, we must keep in mind that a lot of cases done in non-operating room anesthesia situations are done on fit, healthy patients for relatively minor procedures. So it is the cases that actually skew the data are smaller in number, and then they are the ones who are coming from those at-risk populations. And at-risk populations is higher than 60 to 50-year-old patients. Once again, a MAC and sedation once again became bulk of the NORA group. And post-operative nausea, vomiting, inadequate pain relief were the minor complications in about 1% of patients. But major hemodynamic instability and upgradation of care were the major complications of NORA. So overall mortality was higher in case of NORA, but in case of OR, which is 0.04% as compared to 0.02% in non-operating room anesthesia. But if you take the other sites out and only include cardiology and radiology, then the percentage of patients dying is higher in case of non-operating room anesthesia. So these are those two sites where maximum mortality is feared. This is once again our own data, which shows that IV sedation with propofol boluses was the highest kind of, but we haven't analyzed the data, but more recent, if you start looking at more recent figures, we have shifted more towards infusions. This was the earlier experience wherein they were doing those short procedures under propofol boluses. Once again, our own experience, we had 64 adverse events out of the 1,004 cases analyzed between 2019 and 2022. We haven't included 2023 in it. We had 64 adverse events, which form about 6.3%, which is kind of higher. But so this include hypoxia, which was managed with a definitive airway, which means the patients were intubated in 5 cases, managed with an oropharyngeal airway in 9 cases, and others, including nasopharyngeal airways in 3 cases. Hypotension was the most frequent complication, and this was managed mostly with epinephrine boluses, which means we had those short periods of hypotension. And in 7 cases, it was managed with norepinephrine infusion. We had 3 cardiac arrests, 1 in the MRI suite, 1 and 2 in GI suite, unfortunately. Both sick ERCP patients, ASA 4 to 5, and one of them did not survive. We actually had intra-procedure hypertension in 5 cases, bradycardia in 6 cases, and hemorrhage in 1 case, which was successfully managed. So the next question. So does this mean that we should have anesthesiologists present for all non-operating anesthesia or sedation? What do you say? How many of you agree that we should have an anesthesiologist present in? Oh, Dr. Asim, there's a surprise for you. What the GI literature says is, and there were 2 studies, and one was for colonoscopy, and the other one was from gastroscopy. And both of them actually suggest that the presence of an anesthesiologist actually increased the incidence of complications. Yeah, there would be a lot of, as of course, these papers that I saw were then, the original papers were coming from GI literature, but then I looked at anesthesia literature and they said, yeah, fine, because they, when they were calling an anesthesiologist, they were actually, you were actually asking for deeper sedation. So most of these incidents were involved either hypoxia or aspiration. So aspiration was the most common complication. And they said that's because we were providing deeper sedation as compared to what you were. But then this group from cardiology came up and they said, fine, we are considering all that. And then still, the risk of patients of anesthesia complications increases with the presence, and the duration of procedure increases when the anesthesia, with presence of anesthesia, they are actually advocating just like sedation-based interventions in case of pediatric cardiology. So they came up with this. They once again was in the same journal, there was an editorial written by their own colleague which said that, no, what you're saying doesn't really add up. But still, there is some literature emerging that is not very flattering to us anesthesiologists. So there are people who are willing to take over your job. And you would hopefully, if you look at the recommendations from GI literature, the guidelines, they say that just call the anesthesiologist when you lead deeper levels of sedation, you have more complex procedures, and the patient is sicker. So congratulations, you'll always be having more complications because they'll be doing the easy ones themselves. Which brings me to kind of an anecdote which was shared by one of my colleagues a few days back, that she said that I just got a call from GI suite saying that one of our senior colleagues, not from our own practice, from another specialty, that she knew is up for gastroscopy, and so why don't you come over? So this call was made by the patient's husband, who also happened to be a clinician and a senior clinician and a colleague. So she said, because I didn't send anybody, I just walked myself. And what I found was that there was this, she was lying there, and she had a 27 gauge cannula in there and a propofol infusion ready to run. And I said, so what's this 27 gauge? So that's the only vein we could find. And the patient herself actually volunteered that you really won't be able to find my vein. So somehow they managed to get the ultrasound, get a vein, started infusion. I'm sure that call came a little sooner than it would have come when the procedure was started, and that propofol bolus didn't work and she had that swelling. And so there are times when you get called in these kind of situations where you just gone to rescue because and you have a little time to plan and execute. So as the topic said, with greater complexity comes greater responsibility. So our job is to create a safe environment. So Herman and colleagues, they've suggested applying this SAFES model in anesthetic in NORA practice. And so SAFES model actually is one way of organizing the way you approach a problem. And it actually deals with people, which means the skills, training, expertise, decision-making, teamwork of the people. So it's more like humans. The tasks, which mean the sequence of tasks, the interdependencies of tasks, and the protocols. And then you look at the tools and technologies, which means monitoring, delivery devices, electronic support, reliability and usability of all this equipment. Physical environment, which means the space, the layout, the storage, the lighting, and the noise. And that's where everything is wrong with NORA. Because when we walk into an operating room, there's that 200-year history wherein we went in as strangers as we walk into a GI suite or a radiology suite today, and then gradually made our place wherein now no theater design is complete unless you've taken care of how the anesthesia equipment would be placed, what would be kind of the workflow for anesthesia personnel. So these facilities were not designed keeping the need for anesthesia in mind. They came much later because let's accept it that because of the advances in this the techniques and the therapeutic options that they offer on these, we are saving a lot of patients from complex surgeries and hopefully improving the patient outcomes. So, but with those advances, we are actually forced to work in an environment which was not designed for us. So, and once again, the last thing is the organization, the entire organization. Now you are walking into a space which where you do not belong. The best thing you would say is to take your team along, which means you take your assistant along, which could be a technologist. But then what you're doing is it's a two-person team. But a two-person team does not work when there's a crisis. I can bet if you have a crisis and you ask for a tube in a GI suite, nobody is going to hand you an endotracheal tube. It would probably be a flatus tube or a nasogastric tube. So please make sure that when you know that you have. So this is another like diagrammatic representation of the same thing. So let's talk about people. We need to train. We need to train the individuals, and we need to train the teams. More than anything else, we need to train ourselves. And for that, generally, there would be two models. One is to create those specialists who go and work in those areas. But as I said, NORA is not one area. So NORA is GI suite, NORA is radiology, NORA is interventional radiology, NORA is cardiology, and so many places. So you can't really have that one person who is master of these all. So you have to train a team of experts who would be rotating, because we also know that everything comes at a price. So if you are scheduling somebody to cater to NORA, then you'd better have the kind of caseload there. And there's another side to it. It is easier said and easier done in Khan, in Shaukat Khanum, where you have got the kind of those control over scheduling, and you can actually schedule case. Move on to, and it's also very easy in public sector where you can simply say, no, I don't have the resources. But that's becoming increasingly difficult, I guess, Dr. Jordan would say. But move into the private sector, and there the patient has to be done yesterday, not today. So once the patient is there, the patient needs to be done. So that's where the entire organization, communication, readiness comes into play. So you have to have a group of people who are trained and who have done NORA available round the clock. Then you need to have a team. So you are taking those two individuals. Like in our practice, we take our senior anesthesia tech with us, but then it could be you need to recruit more people there. And so need to have friends, you need to have people you can talk to, you need to have people to whom you have explained what you're doing. Training also means that you need to train yourself into talking to the proceduralist and actually understanding the procedure. That has to be a part of the training, because if every procedure has its own nuances, and that could include positioning, that could include access, that could include lots of things. So training in core skills and training in communication skills and team building. Another big challenge would be how to incorporate all this into our postgraduate residency program. How do we rotate the residents? How do we give them the right kind of exposure? Should we allocate that 1, 2 or 3 month slot where they're doing NORA? Then do we have the enough caseload to actually justify that? So it becomes a question of efficiency. So all these needs to be worked out and taken into account. And how do you develop that curriculum? And how do you certify that the person who has done a rotation in GI would be doing equally well in interventional neurology suite in dealing with stroke patients? So that's something that we need to incorporate. We need to draw a list of those core competencies and check for them. The environment, of course. Now, we need to start actually becoming advocates. And please don't look at this. I'll explain what you see is that bandage with a foam wrapped around a device that's interesting. I'm coming to that in a minute. So this like workplace standardization. So we have to become advocates and champions. So all future developments should incorporate anesthesia and the anesthesia workflows into the design. So this talking about the monitoring, one of the every guideline, every recommendation says that you should monitor carbon dioxide. And so how do you monitor carbon dioxide in a patient who is not intubated? So this is one. And so the disclaimer is that I just try to make sure that the uh, the name is not visible, and I am not actually advocating any brand, but this is one such device which actually uses your nasal prongs to monitor your capnography and uses the same nasal prongs to deliver supplemental oxygen. So we find that useful. And after having dropped it once on the floor, some of our smart people actually came up with this protection for this. We we would probably at some point get the industry to work on it and get a safer model, except that we don't have that kind of industry in Pakistan. Hope we have it one day. Gas supplies, once again, is an issue. You do not have central pipelines in those, so you need to have your cylinders. Most of the times, the machine that you get in these areas is the one that has been discarded by the ORs. That probably would have to change at some point, because there's one place where you need reliable equipment, and that's this. But and that probably would change as things evolve. Once again, there is that problem with lightning. Generally, we find that there is low visibility. Organization. Now, it's extremely important to organize the workplace. Have a system for communication, because the worst scenario that I noted and I experienced was that the anesthesiology is not really aware of what the procedure is, doesn't have a good idea of what is happening, what are the likely problems that will happen. And the proceduralist, when they actually see those instabilities or incidents arising, they panic, because, and the last thing the first thing I would recommend is, when a crisis erupts, the first thing has to be that you take charge, and the first person you'll have to tell to calm down and maybe ask them to, with due respect, shut up, is the panic proceduralist, who is just kind of start thinking that I'm losing the patient. So you need to drill the team. You need to recruit people from that team, the usual. So you have done all that hard work for me, talking about human factors and the team training aspects. And Feroz, by actually sensitizing people to the need for natural intelligence and not artificial intelligence. Once again, we need to ensure where the patients are going to land up after the procedure. And it's extremely important to triage the patients who are going to require extended care optimization and all. Just a few words. These are the drugs which are in the pipeline, actually designed to make you jobless or take your job away. Remimazolam, polyseridine is an mu agonist with these two have been recently approved by the FDA. More like, we don't really have data from NORA, but we have data from other sites, which there's their LMA gastro and support systems. And that's where I'm going to stop. Yeah, thank you.
Thank you, Dr. Taki. We're overrunning this session, but we can have one quick question. Thank you.
Excellent. Thank you for this talk. And I know many people are working with NORA overall. I actually had a question which is building on the talks given earlier about how situation monitoring and stress management improve with experience and time. And you showed this data about how NORA outcomes might potentially be worse compared to non-anesthesiologists. And one of the explanations was acuity. Has there been any study about the level of experience of people that we send down to NORA locations? Because being a head of department myself, I know in many places there's some junior most person or a non-consultant who's sent down. It's often the residents are sent down, remote supervision, all these things. Do you think experience plays a role in these outcomes, and whether we can study this properly?
Yeah, I think that's something which is actually universal, and particularly in environments where there's like payment for work models, US, Pakistan as well, private sectors and all, because the workload of NORA so far has been not sufficient to justify dedicated consultants. Probably that's going to change in the coming times to come. And so what we see is either a consultant remotely supervising a senior resident or a very junior fresh fellow in NORA. And so that's where it also becomes important to triage these patients. So you need to at least identify those patients who would require that support and make sure that those cases are assigned to people with more experience.
Thank you, Dr. Taki. Very important topic. Actually, NORA, 3 or 4 at some places, 5 different places, things are happening. So in case of emergency, the communication tools should be defined. In sort of panic situation, you cannot call through mobile phone. Maybe other person is busy. So how we can define either a hotline, sort of landline, overhead paging, or what? Every hospital has different facilities. And the second is to whom to call in case of emergency. The backup team should be defined clearly. That is my question.
Yeah, I think there are 2 options generally that have been discussed, either to call the core team or your parent department. So that depends on the availability and the ability to reach there for rescue. So that I think has to be individualized and decided by that institution and by that team. You may actually in one NORA site decide to call the core team, and in another call the parent team, depends. So these are those things that need to be worked out, and that's where the organization part comes in. Because as I said, what we have realized is that over time, as the complexity of cases has evolved, as the number of cases have evolved, as the challenge has evolved, we also are getting that information, that experience, which is helping us make those more informed decisions. So, of course, it's also improving the training. So I guess, but this is what we are doing, is learning the lesson hard way, learning from the mistakes, whereas we need to now start looking at. So when talking about that artificial intelligence thing, there has been a couple of studies wherein they have built those training models where they can actually predict a patient at risk. And what they've shown is that there are 3 categories of patients who are at risk: raised BMI, obstructive sleep apnea, and AS status. So these 3 are at least the patient specific determinants of an increased likelihood of complications. So you need to identify those subsets and increase your readiness then, but then you need to be ready in all cases.
I think NORA is such a interesting topic, but I guess half the game is won if we recognize it as an entity at par with our theater work. And this is the awareness exactly.
Can you say that again, please?
I think the awareness created by your talk regarding the NORA, that is half the game won. So we can discuss all the details regarding how the NORA for each hospital should be. With that, I thank Dr. Ashraf Taki, and I thank all the speakers for their very informative talk. we conclude the session. Our next session, which is pain medicine and anesthesia session 2, would be over here shortly afterwards. Thank you so much. Thank you.
So it's just the second session is just going to start straight away. Thank you.
Assalamu alaikum, everyone. My name is Sana Afzal Khan, and I'm a senior instructor working in the Department of Anesthesia at Shaukat Khanum. We're very fortunate to have an accomplished team of anesthetists here whose experience and insights are invaluable to our work. So without further ado, I would like to open the second session of talks. It is my pleasure to introduce the chairpersons for these talks. Dr. Jodit Salim, Professor of Anesthesia, ICU, and Pain Medicine at Postgraduate Medical Institute, Lahore General Hospital. He is not only an exceptional anesthetist, but also a dedicated mentor to countless trainees and colleagues. Dr. Jodit is well known for his expertise in preparing candidates for exams, offering guidance that has helped many succeed in advancing their careers. His commitment to education and support has been invaluable, and we're lucky to have him among us today. We are privileged to welcome Dr. Ashraf Zia, Head of Anesthesia, Critical Care and Pain Management, Allama Iqbal Medical College, Jinnah Hospital, Lahore, Chairperson and Dean of Anesthesia Faculty, CPSP, Senior Vice President, PSA Lahore Chapter. He is a distinguished figure in anesthesia renowned for his contribution to both clinical practice and medical education. With an impressive reputation that extends beyond the operating room, Dr. Ashraf has leveraged social media to share insights and knowledge, making complex anesthesia concepts accessible and engaging. Our first speaker for today is Dr. Khalid Samad, who is an associate professor at Aga Khan University and Hospital, Karachi. Dr. Khalid has a specialized focus in cardiac anesthesia. His expertise in this area has been invaluable, and we are very excited to hear his insights today on anesthesia and its environmental impact.
Thank you very much. First of all, I would like to thank the organizing committee of this conference for giving me the opportunity to talk in this forum. Thank you, Dr. Zia and Dr. Jodit. So first session was basically on AI and simulation, stressful thinking, and handling different situations. But now I'm going to talk about a different aspect of the anesthesia, and which is about anesthesia and its environmental impact, approaches to minimize exposure to anesthetic gases and reduce waste. So just for a few facts about our environment. The speed of light is around 300 kilometers per second, which is around 1 billion kilometers per hour. And light year is about the distance that travel Earth year is around 9 trillion kilometers. So this is basically the measurement we do to measure the different sizes in the universe. So why I'm talking about this? Because sunlight is important to us, and it reaches to the Earth in around 8 minutes. And the closest one is the Mercury, and the furthest one is the Neptune. So if you look at the temperature at different planets in the solar system, starting from Mercury is around 167 degrees centigrade to around 400 degrees centigrade at Venus, and at Neptune is minus 200 degrees centigrade. So if we look at our solar system, only Earth has the environment that supports the life, because it has a temperature of average 15 degrees centigrade, along with the presence of the oxygen and the water. Even with the exploration of the furthest of the solar system, which spans over a period of 2 light years, and the Laniakea system, which is basically the system in which our Milky Way is like a small red dot, spans over a period of around 500 million light years. So basically, the scientists are unable to identify any other place where we can survive. So why it is important to us? Because of the change in the climate. And this concept was first given by the Fourier in 1822, but this was not actually evident till the advancement in the technology and the industrialization. So in 1970s and 1780s, we have started looking around that there is increased emission of the greenhouse gases, which has led to the global warming. So basically, we have a natural sources for the greenhouse gases, and this basically helps to regulate the earth temperature. 70% of the light is absorbed and 30% is reflected back, and this helps to maintain the earth temperature in a way we can survive. But with this advancement in technology and with the advancement in the industrialization and with the production of greenhouse gases, this balance is tilting, and this has lead to the rise in the temperature of the earth. So since the release of the AR report in 2020,